So those are the medications, Aricept and Amenda, and those are medications that deal directly with the chemical deficiencies that Alzheimer's causes. Also, there's treatment. You want to use medication to treat symptoms of Alzheimer's, which is like sleeplessness, wandering, agitation, anxiety, aggression, restlessness, and depression. A lot of these medications are depression medications like Celexa and Zoloft and Wellbutrin. Remeron is also used to help with aggression. Cymbalta, Tegranol. They use some sleep aids, which a lot of these you want to use very sparingly because they can also have adverse effects for these elderly people. But sleep aids like Ambien and Lunesta can be used to help them sleep. I haven't really seen this in practice. I was working with quite a few elderly people with Alzheimer's, and really the goal that we had was to really just minimize medication in general. If the Aricept stopped working, we didn't see that their symptoms were improving or that they were still declining, we would take them off Aricept. We would take them off Namenda because the side effects of those diseases and the risk benefit was just not, the benefit was just not there. So, we just would minimize a lot of their medications. But a lot of the folks that we took care of were in the later stages of Alzheimer's where they were just progressing and nothing was really, unfortunately, nothing was stopping their progression. So other medications that could be used are anti-anxiety medications like Ativan, Klonopin. Again, don't see these used very often with dementia patients because it can increase their confusion instead of help calm down their anxiety. Anticonvulsants actually used quite a bit if they have aggressive behaviors, like they're throwing punches at staff or hurting other residents. They'll use these quite a bit to help calm down those aggressive behaviors. Antipsychotics can also be used as well for severe symptoms. It's used. This is like Risperdal, Seroquel, and Zyprexa. So when we get into patient education, we really want to be educating the patient if they're in maybe the mild stages of Alzheimer's, but hopefully they'll have a caretaker there, power of attorney, a spouse, or a loved one that's going to be listening and learning as well, because sometimes their memory and their judgment and their learning capacity is just not intact like it was before they had the disease. So you want to educate them on different kinds of dementia because there's different kinds. There's like Lewy body dementia and dementia caused by Parkinson's and drinking and different things like that. Educate them on the risk factors, including age, family history, and other factors. With the family history, it's important to know if the patient's parents or siblings had early onset Alzheimer's, because oftentimes they're going to have early onset Alzheimer's, and the symptoms can be worse with the early onset than with later onset. Also, want to make sure that we educate them on identifying some of the symptoms so that the earlier the diagnosis, the earlier we can start them on medication, and the longer they'll maintain their independence. Some of these early changes are confusion, difficulties with language, difficulty with concentration, problem solving like complex problem solving like paying bills, balancing checkbooks, getting lost in familiar places. And the late stages or late changes, you're going to see more of the aggressive behavior, anger, hostility, depression, sleep problems, hallucinations, disorientation, and problems doing basic tasks like bathing, dressing, and most of those folks become incontinent. With severe dementia, the severe dementia occurs within 5 to 10 years, usually after diagnosis. Continue on patient education. Um, we need to discuss the safety and lifestyle issues um, with the patient, with their caregiver. Um, it's important to note that they're still going to need regular checkups. They need to still take their medicines, eat a healthy diet, exercise, all the things that make us healthy before our diagnosis. It's going to actually help slow down the progression. We need to avoid activities that may be risky. Need to also suggest maybe seeing a support group that helps, with the psychological depressed feelings, um, because a lot of that's going to be a big change. And when they're first diagnosed, they still, the patient realizes that they have Alzheimer's. They might have seen a loved one go through Alzheimer's, and they might know they've seen it on TV, and they kind of know what they're going to be in for, and it can be a very scary thing. So, uh, a group setting or counseling could be very helpful. Um, a lot of people, when they first are diagnosed, live alone, but they're going to eventually need help with tasks such as housekeeping, cooking, transportation, paying bills. Most definitely, there's going to be some safety issues that come up when they become more forgetful. Their memory starts fading more and more. So that's something we'll discuss further in the presentation. We want to make sure that we start planning for the future by having all the paperwork in order, like power of attorney, 5 wishes, having a will in place, discuss what they want done with their health. If they want a feeding tube, a lot of people won't get a feeding tube because they don't want to prolong living their life if they need a feeding tube. But those kind of things and those wishes need to be discussed early on. Establishing a POA and healthcare proxy is very important to help the providers make decisions for the patient's healthcare. Discussing preferences about where they want to live and their end of life decisions and who will pay for their care is very important as well. So for the caretaker, it's important to if they're taking care of them at home, they need to make a daily plan, prepare to be flexible, because things can change. What the patient wants to do can change. Try not to argue, confront them, because they will most likely get mistaken on facts, ideas, things that have happened, history, family history, all that can become blurred as the disease progresses. They want to use memory aids such as a list of activities, phone numbers, instructions. Establish a calm and consistent nighttime routine to manage the behavioral problems at night, because the sundowners is a very real thing with Alzheimer's. As when it gets darker at night, a lot of the Alzheimer's patients and dementia patients become more confused. Want to avoid major changes to home environment, like rearranging furniture. We want to have safety measures in place, like putting locks on medicine cabinets, keeping furniture in the same place, removing any rugs that they can fall on, making sure electrical appliances are put up, install grab bars in the bathroom, set the water heater to below 120 so they don't burn themselves. Um, uh, Gonna have to help with the personal care as well as needed. Speak slowly with one idea at a time to the patient. Um, Let them kind of digest what you're saying to them. Encourage physical activity and exercise. Consider respite care, like adult daycare during the day, to help you out, because caregiver burnout is a real thing as well, especially once the Alzheimer patient becomes more advanced, they're going to need 24-hour care. They're going to be trying to wander, going out of the house, that sort of thing. So it's going to become very important to have these things in place before it gets to that point. Also, it's important for the caregiver to go to a support group as well, because it's going to be very hard emotionally and psychologically on them to take care of their loved one who has Alzheimer's. For hospitalization and discharge, we want to plan ahead before any hospitalizations occur. Um, Hospitalizations can occur for uh, kind of normal medical reasons that have nothing to do with Alzheimer's, but with the Alzheimer's just adds another layer of comorbidity that's going to complicate things when they get to the hospital. So you want to plan ahead by having an emergency kit with legal paperwork, um, including advance directives, power of attorney, that sort of thing. We want to have all legal documents in order regarding your health care. We want to have medical info, including prior medical history, surgeries, current meds, and allergies ready to go. Want to ask questions for the patient, including, how long they're going to be in the hospital, what kind of procedure is going to be done. If they need surgery, are they going to need anesthesia? What kind of recovery times are going to be? Questions that we would ask even with someone who doesn't have Alzheimer's. You're going to need to advocate for. They're going to need to advocate for that patient. So communication, safety, behavior, and nutrition are important to discuss when the patient is in the hospital. Um, we want to make sure that all of the physicians are aware that the patient has Alzheimer's disease. That can kind of guide how they develop their care plan for the patient. If the person with dementia has difficulty communicating, we want to make sure that we tell the staff that so that they can have a plan to make the patient's needs known. We want to make sure that we consult with members of the team member regarding testing, medical procedures, that sort of thing, and actually confirm that that this can be done. If it can be done outpatient, you want it to be done outpatient. You don't want it to have to be inpatient if not, because it can be a very confusing and scary thing for the Alzheimer's patient. Um, if there's any behavioral concerns, they're going to need to know that. They're going to need to know how to, how to calm the person down or what different triggers they might have. If they have a history of wandering or getting lost, there are certain things that they could do, like put them closer to the charge nurse desk, that sort of thing. Keep an eye out, better eye on them. Um, just want to make sure that the staff there at the hospital knows um, the sort of personality and the sort of behaviors that the Alzheimer's patient is going to have. Regarding nutrition, want to share any preferences with the staff. Sometimes, a lot of times, they suffer from anorexia as well. The food doesn't taste the same, doesn't taste good, so they don't eat it. Um, we want to encourage good nutrition and hydration for them as well, and we want the staff to know if there's any chewing or swallowing difficulties. With discharge planning, we want to make sure that we know where the patient's going to go. If they're going to go back home, going to go to maybe an assisted living or a long-term care, or like a memory care, like a locked unit, something like that. Because then, if they need something like that, like they're going from their home to long-term care, they're social workers. You get the social workers involved so that they can help arrange that. That's their job, so they can help you arrange that sort of thing. I'm going to need to know what kind of activities are going to need assistance for after discharge, so the caretaker can plan for that. Need to know when exercise physical activity can resume, because that's an important part of keeping blood flow to the brain and kind of decreasing the progression of the disease. We need to know the safest way to manage pain for the patient, what meds need to be administered, what symptoms they should be concerned about if they, start they're going to have certain symptoms that they need to go back to the hospital or call the doctor about. If they're going home, a family member need to know, um, need to make sure a family member or friend's going to be available to take them, and they need to have instructions on how to handle safety and independent community services available, and how much the cost of home services will be handled if they need that. If they're going to the long-term care facility, want to check out the facility, make sure that they are um, certified to treat individuals with Alzheimer's, and want to see if they're going to be staying there permanently or just for like a rehab stay, and when they'll be reevaluated if they can come home or if they need to stay. The type of treatment, cost of treatment, and we want to go check out the facility, make sure if it's clean and the staff look well dressed and seems like the residents are being well taken care of. Standards of care, it's person-centered care. So it's kind of hard to see these little circles on here. This is slide number 16. So you have, it kind of starts at the person-centered focus, and then the circles start at the top. So 12 o'clock and goes clockwise. So you have detection and diagnosis, assessment and care planning, medical management, information education support, ongoing care, staffing, therapeutic environment and safety, and transition and coordination of care. So you want to make sure that they know the signs and symptoms of cognitive impairment so that we can get an early diagnosis, we can start the medication earlier, increase their level of independence over time, as opposed to letting it get to the moderate or late stages before we do anything about it. A mental status test is important to be done by the physician at this point. This can help with the diagnosis. We want to make sure that we're thinking of the patient's wishes and we're getting to know the patient. We don't identify them as their diagnosis. We want to understand their values, beliefs, interests, likes, and dislikes. We want to recognize their reality, which helps us communicate with them. We want to create a community for the individual that's very supportive and have care practices that that are tailored to that patient. So assessment and care planning, we want to regularly assess the patient for further progression in the disease. We want to assess an opportunity to gather information so we can build a relationship with the person. We need to try to have a collaborative team approach which involves the patient. Sometimes it's very hard to involve the patient because they don't have the cognitive ability to be a part of their own care. But as long as they do have that ability, we want to include them in their care. We want to optimize physical, psychosocial, physical well-being, and increase the awareness of care options, including palliative care and hospice. For medical management, we want to take a holistic approach. We really want to look at their medications, make sure we are discontinuing medications that they don't need. We want to make sure that we are doing the Aricept and the Amenda because it helps with their independence. And we also want to start the talks about the end of life care discussion early because eventually it's going to lead to the patient's death. The practice recommendations for information, education, support for the individual living with dementia and their caregivers. We want to provide as much education as we can to help them prepare for the future, make their house safe, know what they're getting into when they're taking care of the person, how to take care of people, like helping them with ADLs, maybe get them some CNA training or get them some training to help be able to function well with that. The behavior and psychological symptoms of dementia. We want to identify what triggers the patient, implement non-pharmacological practices that are patient-centered, evidence-based, that help redirect them from their behaviors. Um, we want to understand and recognize that the investment required to implement these practices differ across the care settings. In the hospital, it kind of becomes difficult to put the time into, building doing non-pharmacological practices, although we should be doing that. We want to adhere to protocols of the administration in regards to those practices as well. Being supportive of their ADLs, we want to allow them to do as many ADLs to maintain their independence as possible. We, we want to support them, support for when providing support for toileting, content, dignity, and respect for them. A lot of this stuff, they've been doing their whole life by themselves, and now they need someone to help them, or they have forgotten the steps and some of these easy ADLs that they have been doing their whole life. For staffing wise, we need to make sure staff is trained to be able to take care of patients with these, because there is some special needs, and they can really drain your patients if you're not trained to handle patients with Alzheimer's disease properly. We want to establish involved, caring, supportive leadership. We want to promote and encourage resident, staff, and family relationships, and evaluate the systems as we go, see what works, see what doesn't work, and be able to evolve what's going on to help the patient. For supportive and therapeutic environments, we want to create a sense of community for that patient. We want to be able to provide dignity, courtesy, and opportunities for them to make a choice about their care. So that's very important in that environment. And transitions in care, we want to prepare and educate people at dementia about the common transitions of care, which usually they'll start living at home. Sometimes they'll go to an assisted living, and most of the time they will end up at a long-term care facility if they live to that advanced stage of Alzheimer's, unless they have the funds to have a RN, in-home RN 24/7, because that's what it's going to take at the end stages. They're not going to have really any independence towards the end. There's quality indicators, which are quality indicator 1 through 14. 1 is cognitive and functional screening. Number 2 and 3 is medication review for dementia symptoms. Quality indicator 4 is laboratory testing. 5, neuroimaging. 6, cholinesterase inhibitors. 7, caregiver support and patient safety. 8, stroke prophylaxis. 9 and 10, depression screening and treatment. 11, driving privileges. And 12 and 14, restraints. So really want to do, cognitive and functional screening to get our diagnosis in place. It's evidence-based, because once we get that diagnosis in place, we can start treating them with medications, which will slow down the progression, which will allow them to function independently longer. That's basically our main goal, and our plan is to help these people function independently as long as they can, and give them dignity as they go along. 2 and 3, their medication list should be reviewed. They should be on the cholinesterase and the Namendaz and all that if there's no contraindications. Any medications that are not necessary need to be discontinued. If we can do a medication like once a week or once a month as opposed to every day, that's going to help as well. We're going to want to do that. Laboratory testing, want to test really for B12 and TSH levels. because if those levels are out of whack, sometimes it produces symptoms similar to Alzheimer's, which can be reversible if we rebalance those. So that's important kind of as a rule out. Neuroimaging should be done if there is signs of dementia or neurological findings. Um, it'll help also rule out if they might have a neoplasm, subdural hematoma, stroke, normal pressure hydrocephalus, which most of this could be managed medically and reversed. If mild to moderate AD is there, it could let's see, it can decline their cognitive decline. It can delay cognitive decline if they're on the cholinesterase inhibitors. Want to have the discussion about safety with them and work with the caregiver, as we discussed in some of those past slides about, what it's going to look like, what kind of behaviors are pretty common, and what kind of physical limits they're going to have, and what the caregiver is going to have to do to take care of them. So for quality indicator 8, the stroke prophylaxis, dementia can worsen with CVD, so they should have prophylaxis against a stroke because you have Alzheimer's and you compound a stroke on top of that, it's going to be really tough for that patient and it's going to make things a lot worse. We want to screen for depression because that's one of the main symptoms from Alzheimer's disease. We want to treat them with depression medicine because it will improve symptoms of dementia and reduce suicide. If they screen positive, they should be treated because depression worsens the cognitive and behavioral impairment. Number 11, one of the biggest safety issues is with someone newly diagnosed with dementia is driving. So we should talk to them about either giving up driving or have the DMV retest them to make sure they're going to be safe on the road. 12 through 14 is regarding restraints and placing restraints when they're in the hospital and the reasons that they would do that and everything that needs to be tried before they're placed and to help redirect them. If they are placed in restraints, which this is kind of protocol for anyone in restraints, but at least at my hospital, but it needs to be consistent release from restraint at least every 2 hours, face-to-face reassessment by a physician or nurse at least every 4 hours, observation of at least every 15 minutes and more frequently if indicated by patient's condition, and interventions every 2 hours, including nutrition, hydration, personal hygiene, toileting, etc. Home safety, we want to be able to evaluate the environment, make sure avoid safety hazards in the kitchen, like leaving on the stove. That's a big one that you hear about. Want to be prepared for emergencies by having fire extinguishers and different things in place, maybe even one of those life alert buttons. We want to make sure that safety devices are in working order, install locks out of sight. We want to make sure that it's fairly secure because a lot of times Alzheimer's patients can wander and that becomes an issue. Remove tripping hazards, watch temperature of water and food, avoid injury in the bathroom by having grab bars, textured stickers that apply to slippery surfaces. We want to make sure laundry detergent packs and bleach are put up. We want to make sure that there's nothing that could be slippery that they can fall. And we want to assess hazards in the garage and basement and support the patient's needs We want them to feel at home, whether it's at home or in the long-term care. So we should really support their needs and try to tailor the environment to them. And that's it. Thank you.